the last 2 years, there's been a revolution in payment for preventive services that we've never seen before in the United States. In fact, we're embarking on what I would call a decade of prevention. And what you're going to hear today is something you probably don't know about, and that is all the prevention services that your patients can receive, you get paid for, and they don't have to pay a copay. So this is very exciting, and I'm really happy to introduce the panel today of distinguished speakers. The first is Dr. Nancy Lee, who's my new boss at the HHS Office on Women's Health. She comes to us from CDC, where she was the director of the Division of Cancer Prevention and Control, and she managed 130 staff and an annual budget of $280 million. She got her MD from Baylor College and did her residency training in internal medicine at the University of Pennsylvania. She's got an extensive publication list, over 95 articles, and she's actually consulted with NCI, FDA, the American Cancer Society, Planned Parenthood, and many, many others, especially on the epidemiology of reproductive system cancers, contraceptive methods, and HIV infection among American women. So let me introduce Nancy, and she's going to share some important information for you.
Thanks to Susan and all of you all here. I'm very honored to be here to tell you a little bit. I'm going to give sort of the background on what we're going to talk about today, which is these new prevention services and the Affordable Care Act and the intersection of those. And then my panelists are going to sort of delve into those a little deeper. Just to let you know, just the brief thing, why do we do the Affordable Care Act? Well, the health insurance market was working well for the insurance companies, but not for patients and clinicians, and I think everyone in this room is one of them, both of those, and they can appreciate that. Over 50 million Americans were uninsured, and when I started my job at CDC, 35 million were uninsured. So it was an increasing problem every year, and tens of more millions of Americans were underinsured, and people with coverage were afraid of losing it, either because they changed jobs, or they got a serious illness, they had a child with a serious illness, a lot of reasons like that. And medical practices worked without the support they needed and couldn't provide patient-centered care that was safe and effective, and spent a lot of money on administrative costs and instead of direct patient services. So this week is the second anniversary of the Affordable Care Act, and it's already helped millions of Americans. It's already lowered costs. For example, there are new rules that require insurance companies to publicly justify a rate increase of 10% or more, and there's numerous examples now of states being able to sort of impose restrictions on high rates of increase in 1 year. The ACA is committed to improving the quality of coverage for insured Americans, and it requires coverage for preventive services at no additional cost, which is what we're going to be talking about later, and I'll get to that. It also provides options to cover the uninsured. So, example, young adults are now able to stay on their insurance, on their parents' plans until they turn 26. We estimate about 1.2 million young adults will gain insurance coverage as a result of the law. My 23-year-old son, still a college student, is one of those. And so it has had a direct and personal benefit to me, and it's wonderful that he has insurance that he wouldn't otherwise have. And the ACA bans insurers from denying coverage to children based on pre-existing conditions. In 2014, this ban extends to all Americans, but it's already affecting children. And it has already expanded insurance coverage to more than, or it will by 2014, to more than 34 million people. The law replaces some of the worst excesses and abuses of the health insurance industry with strong consumer protections, and it has the potential to bring considerable financial and clinical benefits for providers by reducing administrative burden and creating better opportunities to coordinate patient care. The law enacts comprehensive reforms that will hold health insurance companies accountable, protect you and your patients, and guarantee choice and control. The law also has made a big difference for women. For years, women have had a bad deal in the health insurance market. Women are more likely to be uninsured or underinsured, and, pardon? Oh, thank you. I have to multitask here. They can pay up to 50% more than men for exactly the same coverage. And to add insult to injury, women health plans haven't often covered the care women need, for example, maternity care. The health care law creates equality for women in the health insurance market. In 2014, insurers will no longer be able to turn women away because they were pregnant, had a serious medical condition, or were victims of domestic violence. And women will have the freedom to make important life choices, like changing jobs, without basing them on whether or not they're going to lose their health insurance. Susan alluded to this a few moments ago. So now we're going to talk about these preventive services. And this can get a little complicated, so bear with me, but it's really, in the long term, very good news. For women who have a new private health insurance plan or a private insurance policy that began after September 2010, so that was over a year ago, the preventive services on the next two slides that I'm going to show you have been covered without charge to the woman since 2010. Again, this is private insurance, and these preventive services do not require a co-payment, co-insurance, or a deductible for the woman. But the insurance has to pay the provider. The ACA required that all preventive services which received an A or a B recommendation from the U.S. Preventive Services Task Force be covered by private insurance plans without cost. And it also required similar coverage for all immunizations recommended by the Advisory Committee on Immunization Practices and the pediatric preventive services from Bright Futures. Obviously, children and men benefit by this part of the law, but I'm going to concentrate on the prevention services for women. So here are the services covered for pregnant women. And again, these receive a or a B recommendation from the U.S. Preventive Services Task Force. They are already in effect for women with private insurance. And so what's on this list is what you'll see at the bottom. You can't really read it, but as I understand, you're getting a copy of these slides. It is a link to a wonderful little page in the U.S. Preventive Services Task Force website that lists all of these things. Then for all women, these are already in effect as well. Again, these are covered services that women can receive without having to pay a copay, a deductible, or etc. So it includes in this colon cancer screening, which can be very expensive, mammography, and some of the other sort of screening tests as well. The STIs include chlamydia, gonorrhea, and syphilis. And then, besides screening, women can receive this kind of counseling and other treatment services, notably tobacco cessation interventions, which include pharmacologic treatments, and all of the ACIP recommended immunizations. So if you have patients who have what's called a new insurance plan, and I'm going to get to that in just a minute, a little bit, they can get these now, and so you can start sort of exploring this issue with your patients to see if they want these things. And I would think that we had a long discussion how women can find out by calling their plan if this is covered, and probably your insurance administrator in your office will be able to help you with that as well. Then there was a part of the law that asked for additional women's preventive services. Angela is going to talk more about that in a minute. But the IOM was asked to review the evidence and come up with additional women's preventive services that would be covered in the same manner. And this was released last spring and will be come into effect this August. So I'm getting ready to show you 8 additional preventive services that will have the same rule for women with private insurance who these services will be available to them without any cost sharing. So screening for gestational diabetes, HPV DNA testing, you can read the list. I would like to say that the bottom one I think is particularly important because this allows for at least one well woman visit a year without cost share, without deductible, and it is at this well woman visit that a woman can receive many of these other preventive services. So we really are very glad about these. You'll notice in the middle of my list I have FDA-approved contraceptive methods and sterilization. As you well know, that has been the one that got all the publicity. And I think maybe Alina can talk a little bit more about that. And just to wrap up here, it gets a little complicated, and I put in a link at the bottom of this if you want to read about this. So these are eligible new plans. So what does a new plan mean? Well, it all came about because President Obama said if you like your plan, you can keep it. He didn't want to change it if people liked it. But the normal course of events is that insurance plans change. The insurers decide they need to raise their premiums, they need to change the benefits. So as long as a plan does not do these major changes, they're called a grandfathered plan, and these preventive services coverage does not apply to them. Once they make a change, the preventive services rule will apply to them. And all plans, regardless of the what we call the grandfather rule, cannot put a lifetime limit on coverage. They can't cancel coverage because of mistakes on the application, and they are required to extend the parent's coverage to young adults under 26. We'll see how this grandfather plan plays out, but you can find out more information at that website. And they estimate that over time we will, most plans will move to what we call the new plan. So I really appreciate the opportunity to speak to you this morning, and at the end we're going to have questions, and I look forward to those. Here are some websites where you can find more information. The bottom one, womenshealth.gov, is our office's website, and I encourage you to check that out. There's lots of information there too. Thank you very much.
Our next speaker is Dr. Angela Diaz, and she is a professor of pediatrics and preventive medicine at Mount Sinai. She actually got her MD at Columbia University, College of Physicians and Surgeons in New York, and completed her training at Mount Sinai. She is the director of the Mount Sinai Adolescent Health Center and has been on the board of directors of the New York City Health Department. She was elected in 2008 to the prestigious Institute of Medicine of the National Academies of Science.
Anthony.
Thank you. Good morning. I would like to discuss the role that the Institute of Medicine played in the preventive services for women. The Institute of Medicine of IOM, as we call it, is part of the National Academy of Science, an independent, not-for-profit organization that provides unbiased, authoritative advice to decision makers and the public. At the request of the U.S. Department of Health and Human Services Assistant Secretary for Planning and Evaluation, ASPE, the Institute of Medicine assembled a committee of experts to identify critical gaps in preventive services for women beyond those already identified in the ACA. And the ones that were already there were based on 3 independent bodies: the U.S. Preventive Services Task Force, the American Academy of Pediatrics Bright Futures, and the Center for Disease Control and Prevention's Committee on the Immunization Practice. The recommendations of the IOM, if accepted by HHS, were to become part in the development of comprehensive national guidelines on preventive services for women to ensure the health and well-being of women. The 16 committee members have extensive and diverse expertise, including disease prevention, women's health, adolescent health, evidence-based guidelines, and policy. The staff director of this project was Karen Helsing, and both Alina and I were members of the committee. When the IOM is asked to work on a project, they are given a statement of task by the sponsor. The statement of task for this particular committee was as follows. What is the scope of preventive services for women, not including in those graded A and B by the U.S. Preventive Services Task Force? What additional screenings and preventive services have been shown to be effective for women? What services and screening are needed to fill gaps in recommended preventive services for women? And what models could HHS and its agencies use to coordinate regular updates of the comprehensive guidelines for preventive services and screening for women and girls? The specification, also the other specification, one of them was that the population to be discussed, to be part of the study, were women and girls 10 to 65, that the committee could not consider cost as a factor, and that the recommendations were for clinical settings. Community-based prevention was defined as beyond the scope of the committee, of the study. The committee had held 3 open meetings in Washington, D.C., which feature presentations from experts in all of these areas. The committee also reviewed written testimony submitted by interest groups, professional associations, and individuals, and met 5 times in closed session for deliberation and review of all gathered evidence and to develop the recommendations on a consensus-driven process. The committee defined preventive health services as measures, including medications, procedures, devices, tests, education, and counseling, shown to improve well-being and or decrease the likelihood of or delay the onset of a targeted disease or condition. To guide its deliberations, the committee developed 4 overarching questions. Are there high-quality systematic evidence reviews to show that the service is effective in women? Are quality peer-reviewed studies available that demonstrate effectiveness in women? Has the measure been identified as a federal priority? Are there existing federal, state, or international practices, professional guidelines, or federal reimbursement policies that support the measure? Throughout the study, the committee repeatedly questioned whether the disease or condition was of significance to women, and especially whether it was more common or more serious in women than men, or whether women experienced different outcomes or benefited from different interventions than men. The preventive measures recommended by the IOM committee met the following criteria. The condition to be prevented affects a broad population. The condition to be prevented has a large potential impact on health and well-being, and the quality and strength of evidence is supportive. After the committee completed the report underwent a rigorous, independent, external review prior to its release in July 2011. The committee recommended that 8 preventive health services for women be added. The recommendations are now prioritized and they are all considered important. Recommendation 1, screening for gestational diabetes in pregnant women between 24 and 20 weeks of gestation and at the first prenatal visit for pregnant women identified to be at high risk for diabetes. 2, the addition of high-risk human papillomavirus HPV DNA testing to cytology testing in women with normal cytology. Screening should begin at age 30 and should occur no more frequently than every 3 years. 3, annual counseling on sexually transmitted infections for sexually active women. 4, annual counseling and screening for HIV infection for sexually active women. 5, the full range of FDA-approved contraceptive methods, sterilization procedures, and patient education and counseling for women with reproductive capacity. 6, comprehensive lactation support and counseling and cost of renting breastfeeding equipment. A trained provider should provide counseling services to all pregnant women and to those in the postpartum period to ensure the successful initiation and duration of breastfeeding. 7, screening and counseling for interpersonal and domestic violence. Screening and counseling involve elicitation of information from women and adolescents about current and past violence and abuse in a culturally sensitive and supportive manner to address current health concerns about safety and other current or future health problems. 8, at least one well-woman preventive care visit every year for adult women to obtain all the recommended preventive services, both the one initially included and the one added, recommended for addition by the IOM. The committee understands that several visits may be needed to obtain all the necessary recommended preventive services, depending on a woman's health needs and other factors. On August 1st, 2011, the U.S. Department of Health and Human Services adopted all 8 recommendations from the IOM. The goal of all this is to build a health system where prevention is a centerpiece and where providers practice in this manner, so that provider can really concentrate in prevention and be reimbursed for it. This marks a profound shift away from the reactive care and towards a proactive system of care focused on prevention. Thank you.
Our next presentation is Dr. Alina Selinikov, and she is Vice President and Director of Women's Health Policy for the Kaiser Family Foundation. She holds a PhD in health policy from Johns Hopkins, and she's focused her work really on health care access, health coverage of women, and low income, especially low income and uninsured women. She's the Associate Director of the Kaiser Commission on Medicaid and Uninsured. And in fact, she's passed out to you a wonderful summary of all of these prevention benefits that comes from Kaiser. And she is also one of the members who served on the IOM Committee on Preventive Services for Women. Let's welcome Alina.
So it's a real pleasure to be here. My job is to explain how it's all going to work. And I'll tell you right now, I probably can't answer all your questions. This is very much a work in progress. I just want to say, Angela and I were talking earlier, this has been for both of us, and I can speak for other members of the IOM committee, a career highlight. Many of us serve many times on many advisory committees, but it's very rare that you have a chance in your life to make recommendations that affect billions of women, and I think that there's a great possibility and potential here. I think that the big job that we have right now is to make it work for the women that we serve. So with that, I'm going to get started. Again, I think it's just important for us to have some perspective on the context here. This is important because cost is a big issue. It's a big issue for men and for women, but consistently throughout the healthcare system, cost is a greater barrier for women. Women delay care, they skip care, they don't fill prescriptions, they cut pills at higher rates than men. And we know because there is a gender gap, there's a very large literature that shows that women use more healthcare services and shoulder the burden of costs with more difficulty. And it's not just uninsured women, it's women who have private insurance and women who have Medicaid coverage. As you know, Medicaid has very limited cost sharing, but the population that's served by Medicaid is extremely low income. Dr. Lee talked about many of the important things that the Affordable Care Act is going to do for women in terms of both making coverage more accessible and affordable, banning the practice of gender rating, which is when individual insurance would charge women more than men, even though they were providing the same level of services. That's going to be banned next year and actually has already been banned in many states, my own California as well. A ban on pre-existing conditions, review of rate hikes, and these new preventive services without cost sharing. This, I want to say, is a revolution, okay? We have never had any federal requirements that have told insurance companies what they must cover. Generally, we have, the states have regulated this, and there have been different mandates, but this is a comprehensive view of the preventive services that men, women, and children need. And I think this is very important, but it's going to be very important for all of us to work together to make sure that this actually becomes a reality. This is very tiny, and it's in your handout right now. This is the list of all the preventive services that are going to be covered without cost sharing. So I just put this there for you to get a sense of the scope of this. This is really a very, very important improvement. The ones in orange are the ones that are the women's services. But in the end, that's all. It's going to be incorporated in everything. So what type of plans are affected? Every time I talk about grandfathered plans, when I talk about this at home, my husband's eyes roll over. These are important details, and so I'm going to talk a little bit about how this is all going to work. This is new private plans. This is all employer-sponsored insurance. This is individually purchased insurance, and people and plans who are self-insured, and about 60% of workers are in self-insured plans. So this is a really important change. The states have regulated the business of insurance. So if you have an insurance that's bought and sold in a state, and a lot of states have mandates, and you may have heard around 28 states require contraceptive coverage. If you're in a self-insured plan, it doesn't matter what your state policy is. So this is really an important change. The grandfathered plans, as you heard from Nancy, are exempted. But over time, they estimate that in 2014, there will be 20 million people in plans that are no longer grandfathered. So over time, as plans change their benefits and increase or change cost sharing, we're going to see more and more people that are going to be in plans that are affected by these new private rules. What's important to know too is that the plans that are going to be sold on the exchanges and under the essential health benefits, some of you may have heard about this, they are going to have to cover these preventive services as well. Last month, HHS clarified this so that this is going to be available to all the women in private insurance. However, and this is an important however, these plans specifically don't address Medicaid. They just the women's services in particular don't affect Medicaid. Medicare had some big changes, and you may have heard that Medicare for the seniors did have expansion so that women on Medicare can get mammographies and get a broad range of services, no longer with any cost sharing. For Medicaid, which serves poor and low-income women, there is an incentive for an increased 1% match. As you may know, it's a matched program. But these do not affect Medicaid. These are going to be at the state level, and the states may decide to adopt or not. And as you know, these are very difficult times for states. They also don't apply to the VA, the Indian Health Services, or military health. When do they take in effect? Well, today, all of the recommendations, with the exception of the women's health recommendations, are enforced for new plans. So that was effective 6 months after health reform was enacted. This August, they are going to start requiring that these plans also cover the preventive services for women. So that they actually, it was originally going to be in September, and HHS accelerated the date to August so that they could be responsive to a lot of the young women who were in college, because a lot of those plans start in August, and so they wanted to be sure that they also benefited from this. So what's out and what's in? And you may have heard, maybe, unless you were locked in a room somewhere, about religious exemptions and contraception. And I have to say, I'll speak for myself, I knew that when we recommended that contraceptives be included, that it was going to be controversial, but I had no idea that Rush Limbaugh was going to be weighing in on this. So, it's kind of a moving target, so I think I'm going to tell you kind of what we know so far about contraceptive coverage and what's in and out. For sure, all houses of worship are going to be exempt from only the contraceptive coverage requirement if they wish. So they don't have to be, but if they want to be, they can. Last month, HHS made an accommodation which provided a 1-year delay for religious affiliated organizations that object, and those could be universities and charities, other nonprofits. In those cases, they're going to make the insurer cover it and not the employer. And I think the challenge here is HHS, and the intent of ACA is to extend coverage of these services without cost sharing to women. Trying to balance at the same time respecting the religious rights of different employers and organizations. That's going to be a tricky thing, and so they're going to be spending, basically the next year, HHS, they just actually had a request on comments for proposed rules that just came out on Friday to try to go a little bit further down the road on how this is going to work, because as you may remember I said earlier, 60% of workers are in self-insured plans. And so it's a little tricky when you don't have an insurer or the employer is the insurer in terms of passing off the responsibility for the cost of contraception. Anything else you need to know? A couple of things. If the service is provided by an out-of-network provider, insurers can or may charge patients for the office visit and the preventive service. If the office visit and the preventive service are billed separately, the insurer may impose cost sharing for the visit. If the primary reason for the visit is not preventive screening, the patients may have to pay for the office visit. So one of the things we were discussing was what happens if a woman wants a sterilization postpartum, right after delivery. That is considered a preventive service that would be covered. Does she not have to pay cost sharing or deductible related to that particular service? Lots of issues could come up in that way. Insurers also can use reasonable judgment based on established medical practices to make coverage decisions if the frequency is not specified. So that's another particular issue. Again, the devil will be in the details. So in terms of thinking about considerations for clinical practice, I think one of the big issues, and I think Nancy would agree, is what is a well-woman visit? And if you look at the IOM report, there are a lot of different services that the committee suggested be included. There are no federal guidelines about what should be in a well-woman visit. Lots of different groups have different recommendations. I'll tell you right now, the states are making decisions around what's going to be in the essential benefits package, and so I think it's important for experts like you to be weighing in. Also, how do we adequately train our providers to deliver services, and thinking about now having a screening for intimate partner violence? Do we have enough providers? How do we deal with contraceptive services? And thinking about how do we make the most for the new opportunities. This is a list of resources, and this is all going to be, I think, on the website, and you have the fact sheet. I want to make a special plea that's actually beyond the preventive services. There is a lot of action going on right now at the state level. A lot of advocacy groups are weighing in and trying, because the states are going to be making decisions about what's in the essential benefit package. They need to hear from experts like you about what needs to be included there for women. If we don't hear from you, women's voices will not be represented. I can tell you right now, I'm in California, and we're pushing really hard, and it's a very difficult battle. So I think there's a great opportunity right now, but we need to be heard. With that, I will wrap up.
Okay, we'll entertain questions now. Please come to the microphone.
I have a question. First, I want to applaud all the hard work and the success. I think this is marvelous. However, I don't believe we can talk fully about the prevention of women's health unless we begin to talk about women's mental health. We've heard time and time again